Hello and welcome to today's webinar. My name is Adam and I will be your WebEx producer for today's event. We have just a few housekeeping items to get to before we get started. If you experience any technical difficulties joining the WebEx session or difficulties during the WebEx session, please utilize the Q&A panel located in the bottom right-hand corner of the screen. Please note that as an attendee, you are part of a larger audience. However, due to privacy rights, we have chosen not to display the number of attendees to everyone on the call. During the presentation, all participants will remain in a listen-only mode, and as a reminder, this event is being recorded for rebroadcast. We encourage you to submit written questions at any time during the presentation using the Q&A panel located at the bottom right of your screen. After typing your questions in the space at the bottom, please hit the Send button and be sure to direct those questions to all panelists in the Ask menu. Your questions will not be seen by other members of the audience and will be addressed, time permitting, towards the end of the session. Also, at various intervals, polling questions will appear on your screen. Please take a moment to select your answer and then click Submit, the Submit button to share your response. Results will be shared in a confidential format after the poll has closed. Now, I am pleased to turn the call over to Gail Vernon. Gail, please go ahead.
A very warm welcome to tonight's webinar, Caring for Your Caries Risk Patients with Colgate Duraphat. It's hosted by Colgate Professional. And our speaker this evening is Dr. Gemma, Principal of Chapel Street and Dental Implant Centre. By joining tonight's webinar, you will be, and answering the CPD questions, you will receive 1 hour verifiable CPD. Without further ado, I'm going to pass over to Dr. Gemma Colburn. Thank you.
Thank you, Gail. Okay, so thank you everybody for joining us this evening. I'm sure that you're going to find the programme highly relevant and something that you can use tomorrow in your practices and on a continuing daily basis to improve the care that you give to your patients. So the sun's gone away now. It certainly has here in Telford, so no excuses. Let's spend the next 45 minutes together looking at some very useful information. Okay, so we'll have a look at what we aim to achieve this evening. So as modern dental practitioners, we want to offer our patients the best standard of care and minimise dental disease. So this evening we will be discussing the challenge that an ageing population keeping their teeth for longer presents to us. We're going to talk a little about making you aware about the high incidence of caries in older patients. We're going to talk about a tailored programme that's individualised for each patient and risk factors that are associated with the 55+ age group. So the management plan we're going to discuss is going to be utilising high fluoride products. We're going to start with some background, and then in the middle section we'll be looking at some of the products. And right at the end, we're going to look at some interesting case studies together, so some actual patients. So I hope that will help you all apply the advice practically. Okay, so the elderly population in the UK is increasing. This graph shows the existing situation and the predictions for the future. So the red bars that you can see represent the data from 2010, and the black bars represent the predicted data for 2035. So on the left-hand side, you can see the population by millions, and the lower bar shows the age groups. So if you have a look at the last 2 bars, we can see the biggest increase on those last 2 bars. So in 2010, 10.3 million people were over 65. So, and you can see that the black bar increases by a huge amount in that 60+ group. So in 2018, it's predicted that that will increase to 12.7 million. So this is huge. This is UK-only data, but this is an international trend. So over the next 25 years, we're going to be treating an increasingly elderly patient base. So this next graph shows us the proportion of edentulous adults is falling quite dramatically, and I'm sure that you realise this in your day-to-day practice. This is a great thing. This is a reflection that dentists are doing a good job, better standards of health care and living standards. So if we have a look at this data, this is good. This is a good survey. This is the last adult dental survey from 2009. We're just about to have another one, aren't we? But this is the current picture that we've got at the moment, and it shows that the number of edentulous patients are dropping dramatically. So on the left-hand side, we can see the percentage of the population who are edentulous, and along the bottom, we can see the age groups. So what we're looking at here is patients with more than 21 natural teeth. And if we go through each line, there is an obvious trend here. If you look around the 55 mark, there's been a 12% increase in the last 30 years of patients with more than 21 natural teeth. And since 1978, the proportion of edentulous men has fallen from 24% to 4%. And the proportion of edentulous women has fallen from 32 to 7%. So this trend is likely to continue, and we want to help keep this trend going. So we need to start thinking about how are we going to help these patients, what are we going to do for them. So this is an increasing challenge. We've got an ageing population with more teeth, and in the main, previously, oral health promotion programs have often been aimed at children, but it's important to realise that dental caries is still a main cause of tooth loss amongst older adults. So in 2003, Field's 10-year study looked at dental caries incidence in adults aged 55 to 75, and 60% of tooth loss was still down to dental caries. So I think that this is quite significant, and that to offer our patients the best standard of care, this issue needs to be addressed. Okay, so we can see clearly that older patients would benefit from caries prevention. In the last adult dental survey, 31% of adults had obvious coronal caries. And in that group, on average, they had 2.7 teeth affected. There was a meta-analysis by Griffin in 2005, and this supported this trend. So it's time to start focusing our efforts on older adults as well as children. Caries is no longer a disease of childhood, and the evidence is showing clearly that the risk of root caries increases with age. So we know that older adults may be reluctant to use our services. Let's face it, sometimes lots of patients are reluctant to use our services. We don't fall into that truth category. But this evening I'd like to talk in particular for older patients. What are the barriers specific to them? So if you look at the list on the screen, I'm sure that you can relate to this. And I certainly see this in my own practice. So we need to start thinking specifically, how can we effectively prevent dental disease in these older patients? And certainly effective evidence-based oral health programs are recommended to us as dental professionals. So are you seeing this in your practice? I certainly see this in my practice, and I also see it out on domiciliary visits. So I think you'll probably agree with me that the majority of our work is done on the so-called heavy metal generation. And in my practice, we do have a programme for caries prevention that's specifically tailored to this group. And it involves targeted oral hygiene advice, diet advice, and the use of high fluoride products. So we're all very familiar with risk assessment of our patients. We all do it every day. Some of you will do this very naturally. It's second nature to you. And some of you will prefer a more regimented approach to this with forms and tick boxes, for example. But what I'd really like to do here, rather than just take you through this list that you're very familiar with, is look at these risk factors and think, how do they apply to your older patients? Because I think there are 2 points here. The first is that it's quite surprising how many of these risk factors are more frequent in older patients. So previous caries, high sugar intake, partial dentures, lack of mobility. And the second point, which I think is really important, is that we can sometimes see patients who have previously been a low risk profile for caries, have their risk profile changed to high risk. For example, poor oral hygiene due to limited dexterity and the long-term use of sugar-containing medicines. And the worrying thing, I think, is that the worst risk factors are the ones that the patients have no control over. So things like dementia, which is a huge risk factor and often responsible for creating other risk factors. And it's these older patients in particular that I feel need our help. So we would like to get your opinion now. We would like to ask you a question. You will also see it appear on the right-hand side of your screen. If you can tick the answer that you would like to choose, and then on the lower right-hand side you should see a submit button. So the question that we would like to ask you are, what percentage of your over 55 years of age group is at increased risk? So thinking specifically about that group, what proportion are at risk? So like I said, if you choose an answer, A, B or C, and then on the lower right hand of the screen, click submit. I will have disappeared now and you should be looking at the question. Okay, time's almost up. Okay, so if you'd like to just, at the top right hand side, if you click on the participants icon, and you should see the webcam reappear, you should be able to see me again. So we're just waiting for those results. Okay. So in my practice in rural Shropshire, just over 40% of my patients are aged 55 and over. Oh wow, okay, we've got the results already. Okay, so I was just about to say that it's my feeling that half of those are additional risk. But when I go out on domiciliary visits, I think it's more over 60%. That's interesting. Those results seem to concur with that. Okay, so once again, just click on the participant screen and the webcam will come back on, and we'll continue with the presentation. So there is a need for us as clinicians to have a programme of management for these patients. We need that programme to be evidence-based. It must be evidence-based on good data, sound independent studies. It needs to complement existing advice. We don't want our lives getting more complicated. So, of course, following the delivering better oral health guidance. From a dentist point of view, it needs to be quick and easy. We'll talk about the fluoride products in a moment, but I think you'll all be familiar with the Duraphat varnish. And in my experience, that's a very quick and easy tool to use. And also from a patient's point of view, it needs to be easy. So we all spend many hours talking to our patients, oral hygiene advice, diet advice, with mixed compliance. And the high fluoride products can really help where you've got poor compliance. They're cost effective. In Wales, obviously free on prescription, and in England, free for over 60. So when we look at the approach that we're going to take, we need to bear in mind certain things, that the older population are vulnerable, their risk is increased, the risk is high, our approach must be robust, and it must be built on a foundation of sound prevention. So these high fluoride products are not replacing thorough and appropriate oral hygiene advice and diet advice. In my experience, we do need to be realistic with this, because many older patients face limiting circumstances. Like I said, we're going to look at some patients later that will help highlight that issue. I see this all the time in care homes and in my practice, perhaps widowed patients who are living alone, that for some of these people, their high sugar treats, that slice of cake, that bag of sweets, it brightens up their day. And I'm not going to tell carers to stop giving Jack, who suffers with dementia, a slice of cake in an afternoon, because that's going to affect his quality of life, and it's about getting a balance. So in circumstances like that, the high fluoride products can remain the mainstay of prevention. And of course, specific strategies to combat xerostomia as well. So let's have a look at some data. So there is a clinically proven dose-dependent relationship between the level of fluoride in the daily toothpaste and the degree of anti-caries efficiency. So we all know sodium fluoride inhibiting the demineralization and promotes the remineralization of the tooth surface, and that it's effective on enamel and dentine. This graph summarises the data from a 2003 meta-analysis of 17 clinical trials. So we're looking at good, strong data here. All the trials tested at least 2 products with fluoride concentrations greater than 0 parts per million. on the left-hand side, you're looking at the percentage of the caries reduction and the fluoride concentration along the bottom. So the red dots that you're looking at represent the reduction in caries. So they tested both trials versus placebos and trials versus an active control. And you can see this clear linear relationship between caries reduction and the concentration and fluoride in the toothpaste. And you can see by looking at that graph how off-the-shelf regular formulation toothpaste compares to the higher fluoride toothpaste. And it is quite a big difference. So for the second part of the presentation, I'm going to show you some of the specific products that you can use as part of this management programme. And I do wonder how many of you are using high fluoride products yourselves. We're going to be doing another poll again in a moment, just because I quite like to know, because I'm quite nosy. I myself, I'm a Duraphat 2800 girl, and my friends will tell you I have a very sweet tooth. That's my risk factor, and I've used it daily for 10 years now, and no caries for me. That's not an extensive study, but I'm quite pleased about it. So I wonder who of you is using it and why you use it, and also how many recommend to family members or your own children. So on that note, I'd just like to mention as well that the amount of fluoride that's in these products is within acceptable limits for the amount that's supposed to be supplied at any time for safety purposes, and that these products have been licensed for the use of caries prevention and treatment. So Colgate 2800, it's a prescription-only toothpaste, and it's for daily use instead of a regular toothpaste. It's prescribed as 0.619% in the DPF, and we recommend patients to brush twice daily and to spit and not rinse. What I really like about these toothpastes is the patient compliance, because it's a very big result for a low effort from the patient's point of view. We are simply asking them to change their toothpaste. There are no known contraindications for your information apart from hypersensitivity to the ingredients, and there are no known side effects. So the last time I did this presentation, one of the questions that I got was that if I start prescribing from the audience was that if I start prescribing this for my patients, they're going to want it all the time, and it's going to take up a lot of my time prescribing. We'll go through the specifics of prescribing later on, but I can tell you that once you get used to it, it's not too bad. It becomes part of your routine. I can remember that I found out about Duraphat toothpaste from a patient actually, and that they asked, they were a new patient, and they said, "Oh, don't you prescribe this? My old dentist prescribed this." And I remember feeling that dentist was a bit superior to me, and I got that a little bit from the patient as well. So the point that I'm trying to make is that these toothpastes can be a good practice builder. When you prescribe them, patients feel that you're taking good care of them. So let's have a look at some more evidence. So this is a very well-established trial by Bisbrook, and it's a randomised double-blind trial, which, as I'm sure you know, means that neither the patients nor the treating clinicians knew the concentration of the toothpaste being used. The study looked at 5,439 patients, so that's a fair few patients, and they looked at the DMF index over a period of 1 year. So we've got some very good, powerful data here to look at. So on the left-hand side, you can obviously see the DMF index and the concentration of the fluoride along the bottom. So there were 4 different toothpaste formulations in this study. And what Bisbrook found was that the 2800 toothpaste, there was an amazing 20% reduction in the DMF index in 1 year. So we can see quite strong clinical evidence there that 2800 delivers a greater caries reduction than a regular fluoride toothpaste. So both the 2200 and the 2800 formulations, that was statistically significant reductions in those groups. So again, you know, wow, I think 20% reduction, and some of you are probably aware that there's a similar reduction in caries when studies have compared fluoride-free toothpaste with regular formulation. So I have to say, I absolutely love this product. I think it's an amazing result by changing the toothpaste. It's low cost and it's easy to use. It ticks all the boxes for me. In my practice, I often prescribe this to my heavy metal population, And I approach this group generally by ensuring that I restore them minimally, giving just a couple of basic oral hygiene and diet advice tips that are relevant to the patient and prescribe 2,800. Obviously reviewing on a regular basis, and I always try and use the lowest fluoride formulation I can to get the patient to a stable stage. So if we have a look at the next toothpaste, so the next toothpaste is the Duraphat 5000 formulation. Again, this is a prescription-only medicine. It's prescribed as 1.1% in the DPS, and it's for daily use instead of the regular toothpaste. So it's for high-risk patients over the age of 16, and I tend to prescribe this for those patients who are at high risk of multiple caries or active caries. And obviously, with these higher fluoride formulations, you need to assess the whole sort of fluoride intake of the patient before prescribing. So we're going to look at some more data to support this. So this is really powerful data from the UK, and it's a randomised double-blind trial of 2 toothpaste formulations. The mean age at baseline was 59, so this is data taken from older patients, so it's really relevant. The red bar is showing you the 1,100 formulation, and the black bar is the 5,000 formulation. And we can see at the side of the graph the percentage of lesions that remineralise, so percentage of lesions that remineralise in the study. And the time at the bottom is months, not years. That always amazes me. So, sorry, I've jumped forward. There we go. So the lesions, they were assessed at baseline and then again after 3 and 6 months. So at the start, the hardness of the lesions was categorised as hard, leathery or soft using electrical caries monitor. So with the 5,000 at 3 months, this that was the regular formulation. And then at 6 months, even further improvement was seen. 56% of lesions remineralised after 6 months, compared with 28% with the regular formulation. So I'd like you all to start thinking about what this might actually mean for some of your more vulnerable patient groups. So 56% remineralised in 6 months. So with older patients with some access difficulties, this can mean less dental visits, less work, less potential problems like dental infections and pain, simple things, enjoying their food more and having a better quality of life. So we're just going to quickly look at a different set of data for the same toothpaste. This was quite a recent study, so just under 4 years ago. And Extrand looked at regular toothpaste with the 5,000 formulation. And this was, again, a double-blind trial with 125 patients in 6 nursing homes. And in this study, the participants were having their teeth brushed for them. The mean age was 81, they had 5 or more teeth, and they had 1 or more root caries lesion. So the red bar shows the regular formulation, and again, the black bar is the 5,000 formulation. And the percentage of lesions that are arrested is at the side. So we can see at 8 months a huge difference in the number of arrested lesions. 67% of lesions were arrested in this study, and 90% of those lesions were also classified as hard. So we're going to look at the next product now, which many of you, I'm sure, are familiar with this. It's the sodium fluoride varnish, the Duraphat 2.26%. Now, this works by the formation of calcium fluoride globules that form a persistent layer. And some of you may not realise that that layer actually releases fluoride over several months. It is for professional application only. It's quick and easy. Those of you who already use this product will know that the consistency is great. It stays where you put it, and it isn't awkward to use. We advise patients not to eat or drink anything for 30 minutes afterwards. And you should just be aware that it does contain 33.8% ethanol, so you should avoid it in patients that you'd normally avoid alcohol in. And just to quote delivering better oral health guidance, that states that all high-risk adults should have this varnish applied twice yearly. So again, let's look at the evidence to support us using this product in our practices. So this study demonstrated that the Duraphat varnish prevents root caries from progressing, and it was a really interesting study, this one. It was 215 care home patients living independently. So they were all aged over 75, and there were 3 groups, and the groups were really interesting. So before the study started, all of the participants were brushing their teeth once a day, and everybody, all the participants were using fluoride toothpaste before the study started, bar one. So in group 1, they had monthly cleaning with a hygienist and just the varnish application. Group 2 brushed twice a day with a 5,000 formulation, and group 3 brushed twice a day with a regular toothpaste. So after 8 months, the results showed that groups 1 and 2 had significantly better outcomes. So it was scientifically significant. There was less root caries progression. So looking at this, the progression rates were 20% in the varnish group. There were 30% in the 5,000 group, and the greatest progression was seen in the standard toothpaste group. So the difference between the varnish and the 5,000, it wasn't significant, but the difference between that and the regular formulation was. So Duraphat varnish is the only one in the UK that is actually licensed for caries prevention. And I think that can give you confidence that what you're using on your patients is backed by clinical trials. We spoke about this persistent layer that releases fluoride over a period of a month, and there is actual evidence to support that happens. And you probably apply the same standard to your pet. You know, I always think I treat my patients like I would treat my family and friends, and use the same products on both. So if we have a look now, you'll see a summary of the products. This is quite useful to see. It just lets you know how long the toothpaste would last. So one tube is roughly 1 month, and we're going to look at prescribing shortly, but it's worth bearing that in mind when you're prescribing. I often prescribe 6 tubes will last my patients sort of 6 months, so that you're not getting patients coming in between their recall periods. And we're going to, just for completeness, we're going to have a quick look at the mouthwashes. So there are 2 available. They are available. These are actually available for purchase and retail without prescription, and they work by providing superior fluoride retention in saliva. So we've got the FluoriGuard Daily Rinse and the FluoriGuard Fluoride Rinse, which is the alcohol-free version. It's for ages 6+, and we advise patients they don't rinse or eat or drink for 15 minutes afterwards. Samples of this are available. And the alcohol-free version I find particularly useful in patients with xerostomia. So if we have a look at some evidence, now this evidence is from children, it's the evidence that's available. So this is a Cochrane review, and it's a meta-analysis of 34 independent clinical trials, so it's strong data. And what we're looking at here is a pooled estimate of the prevention of caries. So the DMF prevented fraction here was 0.26, and this was substantial. And they proved in the study that regular supervised use of these mouthwashes would reduce their tooth decay, the children's tooth decay, even if they drank fluoridated water and they were already using a fluoride toothpaste. This was like an extra benefit. And that 1 in 2 children with high levels of tooth decay would have less decay if they used fluoride mouthwash. So before we move on to the next section of the presentation, we're going to do another poll question. So we would like to know, after discussing these products, how many of you are using these products in your practice? So once again, you'll see the poll question appear on the right-hand side of your screen, and you need to click the answer that you would like to choose and then submit at the bottom of the screen. So which products are you routinely using or recommending to your patients to increase fluoride availability in your higher risk patients? So I usually find for my patients that I use a combination. I find it useful. Okay, great. So the poll has ended now. So once again, if you click on participants, you'll see the webcam come on, and we will just wait for the results. Yeah, I like to tailor, we'll look at a specific toolkit in a moment, which is really useful because it just gives you a system to use to tailor the care and some guidelines to follow. Okay, so great. 65% of you are already using a combination of the products and the varnish alone and the toothpaste. Oh, so nobody's not using any of them. That's great. Okay, so if you click on the participants, you should see me again. Okay, and we'll continue with the presentation. Okay, so this toolkit is available to download, and I have a copy of this in the surgery, so I can just go through it, because we have to prescribe based on an individual basis for each patient as clinically assessed by us. So step one in this process, if you look at the red box, it's to identify, is this patient at increased risk? So you'll be looking at your older patients and thinking, do any of these additional risk factors apply to them? And if the answer is yes, then we move on to the second step, which is professional interventions. So as the polls just revealed, you know, we can do a combination of these. We can do the varnish twice a year. We can prescribe either of the toothpaste formulations for active, coronal or root caries. We haven't got to wait for caries. If we identify them at high risk, then we can start using these products, and I think that's a super job to do. And we can also, on occasion, consider using the mouthwash as well if it's appropriate. So then also, like I said before, we're not talking about using these fluoride products as a substitute for good old-fashioned, good oral hygiene advice and diet advice and patient education. So looking at the patient's diet and advising on healthy eating, including carers, and I like to do really good basic sound routine advice. So brush twice daily, spit out, don't rinse, and if you're using a fluoride mouth rinse, use it at a different time of the day. You do need to follow up because risk profiles change, and you know, the risk may increase, it may decrease, it may stabilise. So there's a whole toolkit here available for you to use, and it can help you to look at your patients and think, okay, what would I do? And you can see that the toolkit goes round in a circle. So we will be constantly monitoring our patients because they're going to get older every year. We all are, unfortunately. So the situation changes, and I often look at my own patients. I've been in my practice now for 10 years, and I see patients who were previously really quite low risk become high risk in a short period of time. So let's talk about prescribing. We all like to be efficient. We've all got lots to do in our surgeries, so we're going to spend some time talking about this now. So to make you aware that Duraphat toothpaste, it is available to both your NHS and your private patients. And we mentioned before that in Wales, how wonderful your patients can get this toothpaste for free. And in England, your 60 plus age group can get this toothpaste for free. So there is a self-inking stamp available. It's prescribed either as 0.619% or 1.1%. For your private patients, you can either write a private prescription or you can dispense it directly. This is how we do it at my practice. So we dispense it directly, basically, and it's quite simple to create some ready-made labels that we apply to the product as it's dispensed. And obviously you need to include the patient name, your name and address, and the date of dispensing. So the feedback that I get from my patients when I prescribe these products is great. I think they feel really well looked after. I think it increases their trust in me as a dentist. And I'll just come back to that question again about time and how long it takes to do these things. So my routine in my surgery is that the nurse, I sort of talk to the patient about the toothpaste, and my nurse will automatically start completing the patient details on the prescription form and stamp it with the stamp. I'll then sign that, and then my nurse will then fill in the script logbook. So we're doing the same thing every time, so that helps. And for our private patients, we have a pre-formed template for the private prescription, which is copied and pasted into the patient notes and edited as appropriate. So now that we've looked at the evidence, we're going to see how you can apply this toolkit to your patients. So hopefully this will be really useful for you. We're going to look at 3 different patient profiles that I put together. And these are 3 typical scenarios that I see in my own practice. So hopefully this will help you relate the toolkit that we've just discussed to some of your patients. Okay, so our first patient is Mary. Mary is 87 years old. She's a non-smoker and living in sheltered accommodation. So she has some of her natural teeth and she's wearing a lower full denture. And arthritis in her hands is making toothbrushing difficult. So Mary's a patient who has done well. She has retained some of her natural teeth. She's a good example, I think, of how somebody's risk profile can change with time. So what risk factors, what's the most important risk factor that we can see here for Mary? And I personally think that it's compromised routine. So we have to think, what can we do for Mary? So if we think about the toolkit and visualise it, so we're looking at her risk factors, her compromised daily routine, and we're thinking about what we can do to intervene as professionals, and also what we can do to educate the patient and support her to help herself. So we could review her diet and give her some simple tips on healthy eating. To review medications is always useful, and consider the likelihood of xerostomia. That will obviously increase the caries risk, and I think it's really important that that is identified as a condition. We could apply the Duraphat fluoride varnish twice yearly, and we can prescribe the 2,800 formulation for caries prevention. And then after monitoring Mary and seeing how she gets on, we could also consider the use of the daily alcohol-free fluoride mouthwash, the Colgate Duraphat. Okay, so we're going to have a look at another patient now. Quite a different patient here, a much younger patient. So Steve has all of his natural teeth. He's done very well, and he's got lots of old restorations. I see so many of these patients on a day-to-day in my practice. I'm sure you do too. He's brushing twice daily with a regular toothpaste, but his diet, he's got a high sugar diet and he's a smoker. He's starting to become concerned about his dental health. He hasn't seen a dentist for 2 years. So obviously Steve is high risk. Again, what do we think the biggest risk factor is here? Personally, I think that the biggest risk factor here for Steve is lack of attendance. If he's not accessing the service, then he can't get that support and advice to make those lifestyle changes that are going to be important in his case. And lifestyle changes, as we all know, are the most difficult to make. Steve, he likes to have a good time, he's smoking, he's eating chocolates, and I think he looks quite happy, to be fair, doesn't he? But he's high risk, and if we can encourage him and motivate him to attend regularly, I think that's the most important thing, because we can support him in those lifestyle changes. So again, high fluoride can be the mainstay of prevention for a patient like this as well. That his compliance may not be great. So to motivate a patient like this, we can use plaque indexes. You probably use those for some of your patients. And I've certainly got competitive patients who want to know their plaque score each time they come to see me and beat their wife or their husband. But maybe for Steve, an alternative approach. So he may not be interested in plaque indices. So an alternative is to motivate him with perhaps discussing, you know, we would like you not to have false teeth in the future, Steve. You may not have thought about that. So having those conversations with patients, I think, really helps. So what could we do for Steve? If we visualise that toolkit again, have a look. So his additional risk factors, I think we all agree he's high risk: diet, smoking and irregular attendance. So if we look at, again, as I said, the importance of regular checkups, reviewing his diet and giving him some simple and targeted advice on healthy eating, so real specific advice, and providing appropriate smoking cessation support. Often that involves signposting patients, doesn't it, to appropriate services. If there is evidence, so if Steve has caries, then I would consider prescribing the 5000 formulation. If there wasn't any evidence of caries, then I would consider applying the varnish twice yearly and perhaps the 2800 toothpaste. There are no hard and fast rules here. It's a lot of clinical judgment, but we're all used to that, aren't we? And again, monitoring and supplementing with the mouthwash. If Steve comes back and says, oh, I'm only brushing once a day, then maybe there would be a good thing to add perhaps in an evening. We would get better compliance with that. Although it's not ideal, it's better than not using it. So finally, one patient that I thought would be really useful to look at is Michael. So Michael is 82 years old and a non-smoker. He's suffering from dementia and has problems with self-care. He's in residential healthcare, and he's one of the guys that's enjoying his slice of cake each day. And when I go around the care homes, residential homes, I rarely see patients who are fully edentulous. A lot of these people have still got their natural teeth. Some of these patients are accessing domiciliary care. Some of these patients, you'll see them in your general practice. Their daughters, their sons will be able to bring them to see you. His teeth are being brushed by a carer. So Michael is potentially Mary 20 years down the line. So our first patient, Mary, 20 years down the line, she could be in this scenario. And it's just to make you think about what can change with time. And like I say, I see a lot of these patients on my domiciliary rounds, and they do concern me. So we've said diet advice. We're not going to tell him he can't have a slice of cake each day. I'm not going to anyway. Gosh, the bowls of sweets and the bottles of whiskey I see on my round. So what we need to do is we need to be realistic. So if he was perhaps we would like the carer to brush his teeth twice a day. Often I find that this actually happens once a day. So what products come to mind? I think here, obviously, the 5000 formulation. It's quite important to involve the staff, the care staff, and speak to them as well. I said before that in the past, a lot of prevention programs have been based around children and preventative care. And I think now in the UK that is changing. There are several projects now ongoing in the UK that are working with care home staff to train them. And you guys meet these people as well. People may often come in with the carer, and I think it's important to consider talking to them as well as the patient in a respectful way. And we're quite proud to be part of one of those projects in Shropshire at the moment. So I really hope that you've found that very useful, and go away and start tomorrow. Use it in the practice from tomorrow. It looks like a lot of you already are, so I hope that it was useful and it supplemented what you're already doing. So we'll just have a brief summary. Obviously, we've discussed the UK population is getting older and they're keeping their teeth great. These older patients may be at increased risk. And we've looked at really good evidence tonight. I love evidence that high fluoride products are highly effective in the prevention of caries. Colgate Duraphat has a range of products, so we can tailor this to our patients and do the right thing in the right way. So use the toolkit, get it up on your wall in your surgery. It's designed to make your life easier and improve the level of care that you give to your patients, the gold standard, I think. It's in line with the guidance, delivering better oral health, and on top of that, I think that this is a real practice builder. Okay. So I think that we are ready for...
Thank you, Gemma.
Gail. I'll just pop Gail on screen.
Thank you, Gemma, for a really interesting and compelling presentation. We've received a number of questions, so let's see how many we can get through. But first of all, I would just like to remind people that there is available 1 hour verifiable CPD. As you leave the session, you should automatically be taken to the questions. If not, you will receive an email with a link. Once you have sent your questions, we will return a CPD certificate via email within 2 weeks. So if we could then go on to some questions, so that they can see.
Okay. Oh yeah, sure.
Okay. So let's start with. We have somebody who's interested to know, do you have a particular relationship with pharmacists surrounding the practice that you work with in terms of prescriptions?
Oh, okay. That's a very good question. I work in a rural town in Wem, and we have a couple of pharmacies, so we do have a close relationship with them. I'm guessing the background to that question is if maybe, I don't know if people have experienced problems with pharmacies.
Maybe because
prescribing, because it's 6 tubes for 6 months, it's a fairly big prescription. So we haven't had to do this where I work, but I would suggest that if that is an issue, you know, a simple phone call or walk across the pharmacy and have a chat.
So that the pharmacist understands that it's not like from a medical centre, it's not that the patient has a repeat prescription. They understand the review process. Yeah,
because you couldn't put this on a repeat prescription for, you know, a period of longer than 6 months. You would, if these patients are high risk, of course we follow nice guidelines on recall periods. But if these patients are high risk, then I want to see them at least every 6 months. Okay,
thank you for that, Gemma. Another question is around your practice. Do you promote prevention services specifically to attract older patients to the practice?
Oh, that's a really good question. Can you just repeat it again for me when I have a little think?
So somebody's wondering, because you talked about having a 40% patient base of over 55, but you think it's in relation to, do you let people know that you have prevention in place for older people to come and talk?
Right, okay, that is a great question. The first thing is that because we're in a rural town, kind of the local geography, we attract that patient base very naturally. But also that, no, we don't. But I think really important, word of mouth recommendations, growth of your practice. If you're looking after your patients in this way, then I think, but that's a great suggestion. You know, if you're looking to grow your practice, then yeah, it's a great point to highlight, I guess.
Yeah.
I hope that answers your question.
Thank you, Gemma. One specifically around Duraphat varnish. How do your adult patients tolerate the taste?
I'm going to be totally honest, very, very well. We apply I think you apply an appropriate amount. I also think my patients are very used to it. Perhaps having that, I think the useful thing to do here is if you're not applying varnish and it's new to your patients, you may well get some comments, I guess, about, well, I don't like the taste of this. So I would stress the importance of it and use an appropriate amount. Don't sort of dollop it on the teeth. You do need a small amount, and you can get the little dispensing pads that give you the amount this is to dispense on.
Yeah, we've had a similar question, but relating to younger children.
Okay.
Can you give any advice on that, how you can overcome any issues related or perceived issues related to taste?
Okay. Right, okay, that's great. So what we do with the kids and the adults, we tell them what we're doing and why we're doing it. And then I always say, no new cavities. This is great. Whatever we're doing, this is working. Well done, you've got really strong teeth to the kids. The kids love that.
Thank you. Thank you. There's been a question around how can we get hold of a stamp to aid us prescribing?
Okay.
You can answer that one. So they are available, and you can go on to www.colgateprofessional.co.uk. And if you're registered on there, you can request stamps to be sent out to the practice.
A lot quicker. Like I said, my nurse is, I'm having a conversation with the patient, my nurse is not waiting for me, she's stamping, she's getting the prescription filled in, and I just sign it. It's really quick and easy.
Okay, that kind of leads on quite nicely to talking about the team. Because somebody's mentioned here that you talked about having the conversations with patients to motivate them to change the often ingrained habits. Can you share ideas on how you can get the rest of the team aligned with you so that you're all, how do you get it so that that's a practice message?
Okay, so that's great. I'm very blessed by the way we have a really great team. Try and look after them. Because if you've got a consistent team and you've not got the high staff turnover, that really helps with this. To be more specific, we have a practice mission statement, which really helps. And our practice mission statement is that we want to take care of our patients, provide the best service, they can eat comfortably and smile with confidence. And that is in our staff room, it's up in the surgery. So we've got a central message, and then we reflect on that message at every team meeting, at how we deliver that to patients. Can I just see that question again, because you've written it down? So how we get the team aligned. So yeah, so I think a mission statement, it sounds a bit cheesy, but it's really helped my practice. And we're all singing from the same sheet, basically.
Fantastic, fantastic.
And allow your extended team to talk to the patient. My nurse will often have these conversations. While I'm in the room, everybody's having the conversation. I think that helps. I hope that answers your question.
Just time for a couple more questions. You mentioned about speaking with carers, but sometimes is it overlooked, people living in their own homes, how you can communicate with other family members to make them aware of what makes them high risk?
Okay. Gosh, that's a great question, isn't it, as well? Really good question, guys. Okay, so with the carers, they've kind of got that relationship, haven't they? They come in as a chaperone with the patient, and I mentioned doing this in a respectful way, but it's appropriate, isn't it, in that scenario? You have a carer who is defined as a carer, and I guess with next of kin, if they're just bringing their mum or dad into their checkup, it's tricky to be a bit more respectful, isn't it, and involve them perhaps without appearing condescending to the patient in the chair. So I think that perhaps have the conversation with the patient, but I would just change my body language slightly. So I would involve the person if they're in the room, which they often are, because they've helped them in and out, but by getting eye contact with the family member and sort of asking them questions about what they do and involving them in the conversation. And then that opens it up that perhaps they enter the conversation. I would hate to turn around to somebody's daughter or son and say, oh, you know, you should be getting your mum to use this while the patient's in the room. I wouldn't think that would be appropriate. I think that answers the question, Gemma.
Yeah, I think that's great. Thank you. They're still coming in here.
Okay. We've got a bit of time, haven't we?
So yes, we'll go through. Somebody here is mentioning head and neck cancer patients.
Okay.
Especially after radiotherapy.
Yeah.
And this person is saying they regularly prescribe 5,000 for these patients.
Yes, definitely. Really good point.
I guess with the aging population.
Obviously yes, it's more frequent, isn't it?
And there's somebody here saying, as a private practice, can't we sell the toothpaste? As private prescriptions are expensive.
Oh,
so yes.
So just to go over that again, that's exactly what I meant. So if you're a private practice, you can do your private prescription and send the patient off to the chemist, or you can dispense it directly. So we put a copy of the prescription into the patient's notes, and then the patient goes out to the desk and it's dispensed in front of me. So the receptionist will get it out of the stock cupboard, apply the label, I will check that that's been filled in correctly and hand it to the patient. So yes, that's how we do it, because it's cheaper, you're quite right.
Now, a few people have mentioned using Duraphat to reduce dentate hypersensitivity.
Yes.
I know that is not an indication for it.
No, and I'll be totally honest about this. I think it's 50-50. I think that sometimes it works and sometimes it doesn't. And it's like any advice that we're giving our patients. We make suggestions, we review. If it's working, then great. If it's not working, then try something else. I actually think the varnish is fantastic at reducing sensitivity.
Yeah.
And I'm sure lots of people out there have got first-hand experience of that.
Okay.
Or make sure that they're not rinsing it off, because obviously that makes a big difference.
Yes.
The sensitivity issue.
Yes. Somebody here has a concern around fluoride toxicity. Just in, and I think this is maybe more around advice, that patients can sometimes get worried about, from a patient perspective, worried about too much fluoride after a number of years of use.
Yes. Okay. So it wouldn't be, what am I looking for? Come to me, you're probably all shouting this word out at the computer where it builds up an effect. It wouldn't be that, it's not that kind of effect that the body excretes this fluoride, it doesn't build up. And these are licensed products, so I feel confident in the Colgate brand because it's licensed, it's tested appropriately, and it's based on good evidence. So that's why I tend to use those products for that reason. Appropriate use and appropriate amounts. And perhaps the point to make there is, you know, if you've got patients that you're prescribing this to regularly, at every checkup I say, you know, you're not rinsing, using a small amount, make sure you spit out any excess. I think you need to keep giving patients those messages.
Terrific.
Okay.
And then maybe one last question, because you've mentioned about some work that you're doing out in the community.
Yeah.
Somebody has a question around, are you working with your commissioners specifically on older people?
Okay, so this is interesting. So we started on a voluntary basis, so just going out to local care homes on a purely voluntary basis. We had local interest, and it is now a pilot project. And the pilot project is being funded by the NHS. We have employed members of staff, employed DCPs, and the dentists work on a voluntary basis. And it's a 3-year pilot. It's called, oh my gosh, I'm having a complete blank, how embarrassing. It's a project in Shropshire, Care to Smile. So Care to Smile project. But there are similar projects all across the UK. I think people have really opened their eyes to this.
Could I just ask quickly then, if we do have 1 minute, you talked there about the wider team, so do you utilise skill mix?
Yes, yeah, we do, and we find that is so useful. When we do the care homes, we go in and it's a screening process that the project is involved in. And so I will screen the patient, will say, we need Duraphat varnish here, and the DCP comes in and does that while I'm moving on to the next patient. So brilliant. In that domiciliary setting, it makes it really effective. In my private practice, then also, if I want to see a patient 12 months maybe, but I want the Duraphat varnish applied every 6 months, then my therapist would do that for me at the 6-monthly review.
Brilliant.
Okay.
Thank you very much.
Okay, thank you, Gemma.
So that's it. So just a huge thank you to Dr. Gemma Cockburn for a very insightful presentation, great questions, and also thank you to you all for joining tonight's webinar. Good night.
Good night. Thank you for those questions, guys. That was great. Thank you.